So Todd is currently head of the Technology Innovation Center for the administration. He had formerly been Chief Technology Officer for Health and Human Services, and we're looking forward to Todd to talk to us about his topic, which is unleashing the power of data and innovation to reverse diabetes trends. Todd?
Hello. Good morning. How is everyone doing? Fantastic. Well, it's wonderful to be here at the first ever Diabetes Innovation Conference. Thanks so much to the Johnson Diabetes Center for triggering this and driving it. It's incredibly exciting to be here. And what I'd like to do today is really talk about a story of potential diabetes transformation in three parts. It's really a story of the incredible innovation that's possible if you begin to leverage emerging trends in data and IT and really apply them in ingenious and creative ways to diabetes care. So first of all, imagine a world where open data fuels new products and services of all kinds that improve the lives of Americans with diabetes. How many folks here have heard about the Health Data Initiative? Okay, so most haven't, or actually a lot of people have. Can I have one more show of hands? Wow, that's actually an incredibly high percentage. Well, so for the rest of you, just really briefly, the Health Data Initiative is an effort that the Institute of Medicine and the Department of Health and Human Services started a couple years ago. And the whole idea was actually to replicate, in a lot of ways, what had happened previously with weather data and GPS data. So the US government, you may not know, has actually been collecting virtually all weather data in the country for quite a long time now. But several decades ago, it did something incredibly interesting. It started to actually make this weather data downloadable by anybody for free without intellectual property constraint. That then actually fed an enormous amount of innovation by innovators outside government who created the Weather Channel, Weather.com, iPhone weather apps, weather insurance, and much more. The government ran a similar play in the 80s when it began to liberate access to the global positioning system for civilian and commercial use. This then spawned everything from precision crop farming to navigation systems, of course, to Foursquare and location-based applications on your mobile phone, and much more. And so the whole point here is that the government had these information resources, decided to actually open them up in so-called machine-readable form, which basically means that computers can ingest this data and use it as fuel. And made this data available, these information resources available to ingenious innovators and entrepreneurs of all kinds outside government who then, at no cost to the taxpayer, took that data and turned to all kinds of tools and services that improved our lives in so many ways. So the Health Data Initiative is the latest effort by the government to actually run this play. To take information ranging from where are all the hospitals and nursing homes and what is their performance, to what's the latest information about drugs filed with the Food and Drug Administration, to what's the latest information about diabetes, asthma, diseases, medications, et cetera, compiled by the National Library of Medicine. And to actually not only make this data public, but actually to take the public data and make it machine readable. This is actually a critical distinction. So there is data we're making public for the first time, and that's great. But actually, maybe less sexily, but equally importantly, there's a ton of data that HHS and other folks have made publicly available, but in forms that are unusable. And what do I mean by that? Well, what I mean is that they've been made public in the form of books, in the form of PDFs, in the form of websites you can go and ask a question and get an answer from, right? But ask a developer whether that's useful to them, and they'll say, really, no. Not really, not so much. What's really useful is if you actually make the underlying data in the book or in the PDF or the website a downloadable file, if you make it into something called an application programming interface. Who here knows what an API is? Okay, what a cool audience. I love this audience. So for those of you who don't know what an API is, it's an application programming interface. Just think of it as a kind of a port you put on top of a data set, a database that enables a third-party developer platform app to query the data set and actually auto pull out, kind of machine to machine, the data that is needed. If you actually ever go to a party and there are a bunch of developers there, you want to get popular very quickly, just say you'll API something, okay? Then people will really crowd around you, get very excited. And just to give you an example of how powerful this can be, I want to actually talk about one specific data set that has been API'd recently that could be very relevant actually to a lot of your work. And this is actually a new resource called Medline Plus Connect. Medline Plus Connect. Who here has heard of Medline? Okay, so everyone, right? So Medline is this fantastic website, right, maintained by the National Library of Medicine that has the latest, greatest information about all kinds of health and medical and wellness topics written in language that patients can understand. So incredibly valuable, right? So NLM actually recently did something even cooler, in my opinion, which was that they decided to actually make this available as a API. And what that specifically meant was they took all the information about diseases, conditions, medications, lab tests in Medline Plus Connect, and they actually broke it down to specific chunks and then mapped these chunks of content to individual lab test codes, individual medication codes, individual diagnosis codes, and then they set up a service, like a machine-to-machine service, that enables any electronic health record, personal health record, health management app in the universe to, for free, query Medline Plus Connect and say, look, I've got a patient with, or I'm interested in this combination of diagnosis codes, medication codes, lab test codes. The Medline Plus Connect will then spit back a customized patient education package that is actually tailored to what you just asked in terms of the combination of conditions, medications, et cetera, and send it back to you in an electronic package that's ingestible by the electronic health record, by the personal health record, and actually surfaceable real time in the workflow of the doctor's office or the patient, et cetera. It's like having the National Library of Medicine, basically with its continually updated mass of patient language written content plugged into your medical office, plugged into your patient portal for free on an ongoing basis. So this is what we're talking about, right? It's actually taken this incredible base of content and not actually making people go to a website to find it, but actually delivering it in customized form wherever the patient or doctor needs it. One of our favorite laws in the universe is something I call O'Reilly's Law. It's named after Tim O'Reilly. He doesn't call it a law because it would be very self-aggrandizing for him to do that. But O'Reilly's Law states the following, right? If you want data to be helpful to people, right? If you really want information to be helpful to people, don't make them find it. Make the information find the people, right? Wherever actually the people need the help and get that help to them real time right in their workflow. So this is actually what we're talking about. We're talking about not just making new data available, but making existing data usable. Usable by third-party developers, entrepreneurs, innovators to apply data real time where people need it to help them improve their care and their health. And then finally, one very important activity that we discovered we had to engage in is that if you really want to stimulate innovation using the data, you have to actually let people know that the data is there for them to use to innovate, right? So one of the things we like to say is, look, data by itself is useless. Useless. I cannot feed my baby daughter data, as much as I'd love to, because I love data, but she doesn't need data, it turns out, right? I mean, I can't pour data on the head of a diabetic and make them well, right? I can't actually pour data on a wound and heal it, or a broken bone and restore it, right? Data is only useful if it's applied. If it's applied to create actual benefit. And that requires appliers. So here's a question for you. If you make a bunch of data available in machine-readable form, but no one knows it's there, will it create any benefit? Probably not. Probably not. So it's very important to actually find and engage the appliers to actually educate them about that data and actually then unleash them to take that data and turn it into concrete benefit. So what HHS started to do a couple years ago is started to do things like hackathons. It started to do things like meetups. It started to do things like data paloozas. Has anyone here actually been to one of our data paloozas? E-Patient Dave, of course, is like the patron saint of data paloozing. But for the rest of you, data palooza may sound weird to you that a senior U.S. government official is saying the word data palooza on stage, but it's actually becoming something that's a tactic that the government is using and others are using. And a data palooza, quite simply, is a showcase where innovators can actually learn more about data and celebrate what has been done with the data, showcasing products, services, programs, features, et cetera, that the data have helped to power and the benefits that these innovations are then creating. And this is all done in the hopes of actually sparking more innovation, inspiring more innovation, more awareness about the data, more awareness about what you can do with it. And just to show how fast this can move, we started the Health Data Initiative with Institute of Medicine March of 2010. And we convinced 45 rather skeptical entrepreneurs to come to a room and learn more about data we were making available. And actually, they got very interested in the data. And that actually started to spark a chain reaction of people building stuff with the data, we releasing more data, people building more stuff with the data, we releasing more data. And pretty soon, basically about 2 years later, June of 2012, we held our 2012 Health Data Palooza with Robert Wood Johnson Foundation, Institute of Medicine, and California Healthcare Foundation, and many others. And this was 1,600 people in a room for 2 days at the Washington Convention Center, where 242 companies and nonprofits basically competed in an American Idol-style competition for 100 spots, 100 spots that folks could actually use to present their innovation, their data-powered product or service to these 1,600 folks. So very, very exciting. And one of the things that was actually most exciting to us was that these 242 companies and nonprofits, their innovations that they had built required no new legislation, required no new regulation, required no new expenditure of taxpayer money. All we did was basically take data that you've already paid for, information resources sitting in the vaults of the government, and we jujitsu'd it, if you will, into the public domain in machine-readable form, right? Let people know it was there, and then innovators did the rest at blinding speed. And it's a virtuous spiral of awesomeness, more data being released and more innovation happening that is really, really inspiring to see. And a lot of it is actually incredibly relevant to the task we're talking about here today. So just as one example, Sanofi Aventis actually has engaged for the last couple of years now as part of the Health Data Initiative range of activity in a data design diabetes public competition for the best innovations that leverage the power of open data and human-centered design to meaningfully improve the lives of diabetics. And this year, there was a startup called N4A that won the competition. And there was this wonderful column in the Huffington Post by Rosina Samadini that talked about N4A as the 40-year-old startup. Because was it a couple of hackers in a garage in Palo Alto who built something? Actually, no. It was the National Association of Area Agencies on Aging, working with the National Health Index, that actually pairs in a joint venture field workers who can visit patients in their homes with the power of data to really help pinpoint where diabetics need help, what kind of help they need, and get it to them on the ground, human to human. And this actually is an illustration of another very important principle, I think, to keep in mind as we think about how data and innovation can help power improvement in diabetes care. I think when people talk about applying open data, for example, they all too often think about apps. They think about literal iPhone apps or Android apps, and that's great. Apps are cool. I like apps. But a lot of the most profound innovations, I think, driven by open data that we're seeing are not apps, but they're actually information enriching the activity of humans, human-powered services. Like N4A, which is very, very exciting. So there's huge opportunity using open data from the government and other sources, open information resources to fuel new products and services that can improve the lives of Americans with diabetes. So that's one world where this open data can fuel new possibility. There is a second thread I'd like to talk about. Imagine a world where we combine new payment approaches and health IT infrastructure to drive rapid improvements in diabetes care. There is so much exciting work happening, as I think you all know, on this front across the country. And just as a backdrop, we now have more than 30 pioneer accountable care organizations around the country, soon hundreds of shared savings accountable care organizations across the country. There are markets in the Hudson Valley, for example, and elsewhere where upwards of 70% of doctors operate in patient-centered medical homes. Over the next year, we expect that half of all care in the United States will actually be delivered by providers who are supported by electronic health records. This is a whole new ballgame. This is a whole new ballgame in terms of what is available as a platform to help improve diabetes care. And it's not automatic that improvement will happen, but if you actually really thoughtfully think about and work hard to apply these new payment environments and IT infrastructure to diabetes care, the improvement that one can generate can be phenomenal. So for example, I'm sure you all are familiar with the work of Better Health Greater Cleveland, yeah? And the research that Randy Siebel recently published in the New England Journal, where he found that basically in the target population with the activity they were engaged in, nearly 51% of patients in electronic health record-powered practices, 51%, received care that met all of the endorsed diabetes care standards, which is actually a very rigorous standard. Only 7% of patients at paper-based practices received this same level of care. In practices that had EHRs, had annual improvements in care that were greater and were achieved faster. And patients at electronic health record practices show better results regardless of their insurance status, regardless of whether they were privately insured, uninsured, Medicare, Medicaid. All payers, all patients benefited. So this is very exciting. And you know, for those of us who've been on the ground working in these kinds of environments, again, it is not automatic. You don't just add software and change payment and boom, right, have care improve. But I think the message is that if you do have electronic health records, if you do have the right kind of payment environment, you can actually do things and scale activity in ways you couldn't before. It's still a ton of hard work, but the possibilities are very exciting. There are other examples of how payment for quality and payment for health and electronic health infrastructure is actually catalyzing breakthrough improvement. Everyone here is familiar with the beacon communities? Beacon communities, so these are, and do we have beacons here? Woohoo! Rock on, excellent. So if you really want to know what's going to happen in America, I think at the intersection of IT and payment, you know, if you want to see what's possible, I think one of the best places you can go to actually check this out and really learn about what's happening, what's working, what's not working, and how to scale what is working, are these 17 beacon communities across the country that are really taking the reins on this challenge of how do you apply health IT to make care actually better. So I'd like to actually talk about a couple of them. So Bangor, is Bangor here? Bangor, Maine? Check out the Bangor, Maine beacon community. They have actually been enrolling patients in intensive care management services. And again, this is a theme of, you know, it's not just give a patient an iPhone app, you know, and call me in the morning, right? I mean, that's just not what we're talking about. They actually are providing digitally enabled intensive care management services where the care managers to whom the patient is assigned works in a digitized environment with electronic health records to help identify high-risk patients, technology to support care planning and coordination, access to health information about wherever the patient happens to go. In the first 6 months of enrollment in the program, check this out, there are 1,438, just over 1,400 patients in the program with diabetes, CHF, asthma, and COPD. First 6 months, hospital admissions were reduced by 43.7%, emergency department visits were reduced by 38.4%, walk-in care visits reduced by 47.8%, because actually folks were kept healthier proactively through the power of intensive care management enabled by electronic health records and health information. So that's actually very, very exciting. Still early, you know, but obviously very exciting. Cincinnati. Anyone here from Cincinnati? Woohoo! All right. So as you may know, I'm a huge fanboy of what's been happening in Cincinnati. I'm actually from Ohio back in the day, and so huge fan of what Cincinnati's been doing actually now for a very long time, right, to leverage the power of information and IT to improve care. And just another example in the litany of hits emerging from Cincinnati. I think everyone here knows better than anyone probably in the universe that unmanaged diabetes can lead to unnecessary hospitalizations, visits to the ER. Unfortunately, when this happens, as all of us know, all too often the primary care doc isn't actually informed that this has happened, which then, you know, creates problems and can lead patients to further risk for a readmission or a repeat visit to the ED. So the Cincinnati Beacon community, led by HealthBridge, has gone live with a emergency department and inpatient alert system that's actually letting primary care docs know. Crazy idea, letting primary care docs know when diabetics have been actually admitted to the hospital or hit the ER, which is really critical information to know if I'm your primary care doc. And this now enables primary care docs to proactively think outside the practice and better support the needs of their diabetics. So just a simple idea, but one that is a game-changing one, and many of the most game-changing ideas I think we're going to find are the simplest ones, leveraging IT, leveraging information exchange to improve care. So that's very exciting. So not just a world of open information, resources that are machine readable and usable as free fuel, but also a world where payments changing and where health IT is advancing and providing a whole new platform upon which to work to improve care for diabetics. And then finally, last but very much not least, imagine a world where not only open data is happening, where not only payment is changing and health IT is advancing, but a world where we actually tap into, in my opinion, the most underutilized and potent resource in healthcare. What would that be? The patient. This is a phenomenal crowd. They already know everything. So the patient. I think if you look at really virtually every major transformation of an American industry, American product sector, service sector, it's been really driven ultimately by consumers, powered and scaled ultimately by consumers. And we have an unprecedented opportunity to be part of a similar movement in healthcare, and one that's actually aided and abetted in great degree by data. So is everyone here familiar with I'm sure you all are, the Blue Button initiative? Who here actually is familiar with it, just so I know? Okay, so actually fewer people than on the others. So Blue Button, just to briefly recap, is an initiative that was started by the Department of Veterans Affairs and the military and Medicare about 2 years ago. And it was a very simple idea, which was let's allow a veteran to go to myhealthyvet.gov, a secure website, log in, authenticate themselves, and then hit a blue button that enables them to download a copy of their own health information. Very simple, right? And DOD actually did the same thing, and Medicare did the same thing. And at the time, it was actually a very, very quick, very quiet initiative. Secretary Shinseki asked my teammate Peter Levin, the CTO of the VA, well, how many veterans do you think will actually download their own data? And Peter said, well, if it were a breakout hit, but maybe ultimately 25,000 veterans might. 25,000 veterans might choose to get a copy of their own data. So with virtually no marketing, because most people still don't know about this, about just under 2 years later, 1 million veterans, members of the military, and seniors have downloaded a copy of their own data multiple times each. So it turns out people really do want their own data. And stories have emerged about what people are doing with it. So for example, this is actually a fact that not a lot of people know, but about half the care that veterans get is outside the VA system. And so there are veterans who've testified that, look, all I did was just take my record and print it out. And I started carrying it with me from doctor to doctor. And one doctor told me, thank goodness you gave this to me because I didn't know you were on this med. You didn't tell me that. And I was about to give you another med that would have actually interacted with that med and put you in the ER or worse. And so I think there are a lot of examples. I think all of us can come up with examples in our own lives, right, about how the right information at the right time is literally life-saving, or at the minimum, radically improves your prospects. So that's what's happening with Blue Button. And I think one of the most interesting things that's actually happened is that as we were doing this, word started to spread in certain circles, and we actually got questions from folks in the private sector. And the most interesting question was, are you allowed to do that? We said, can you repeat with a little more detail? What do you mean? Are you allowed, under HIPAA, to let patients electronically download a copy of their own data? We said, yes. Yes, you are. In fact, it's the patient's right to get a copy of their own data. So once that was clarified, and actually, by the way, I think there's no sub-regulatory memo that we could have possibly written that was as convincing as the VA, the DOD, and Medicare just doing it, right? Because either it's legal or you'll have some spectacular co-defendants, yeah? So that was really convincing that we'd actually done it, and so the other folks started to do it. Like Aetna did it, United Healthcare did it, Walgreens is starting to do it, McKesson actually, Blue Button enabled their Relay Health patient portal, which has 200,000 doctors using it. So it's starting to spread. In fact, we've launched a program called Blue Button for America now, which just aims basically to spread the word. In fact, it's legal to give patients their own data. In fact, beyond that, it's their right to get their own data, to promulgate a very simple technical protocol that you can adopt to enable this to happen securely and to improve that protocol. The initial Blue Button file was actually an ASCII text file. And now actually we're going to add another option, which is the consolidated CDA that EHRs are now all being built to spit out. On top of that, feedback we got from patients and from doctors and from technologists was that while this download thing was cool, right, that for patients who actually were in a serious spot or in a chronic spot and had a lot of stuff changing in their care, that making them go to websites and log in and hit a blue button and download files and upload files, that was kind of a pain. So there's a project that the Office of National Coordinator for Health IT has just started called Auto Blue Button, AUTO Blue Button, which you can check out. Anyone can join. It's an open collaborative project, and it basically aims to create another technical protocol, open technical protocol people can adopt that enables a patient to direct a holder of their information, be it an insurance company or the VA or a provider, and the patient can direct, in this case, the holder of information to send securely on an ongoing basis until the patient says stop, their information in a feed to a destination, authorized destination of their choice, like their personal health record, right? So for example, you can imagine a diabetic saying, okay, well, I've got my information in these 6 different places. What I'm going to do now is ask each of the 6, to send securely my information at my direction to my personal health record account on an ongoing basis, so I, my loved ones, and my providers in general can have access to that record. So it's really patient-intermediated information exchange, which I actually think is an X factor in the whole information exchange universe, and one I think that's going to get a lot of traction. So this is also being, of course, aided and abetted by the latest features of our meaningful use program, where now electronic health records, to comply with stage 2 meaningful use, are going to give folks the ability, providers are going to give folks the ability, patients the ability to view, download, transfer their information, so that will help enable additional broadening and deepening of the ability of patients to get their own information, which is very, very exciting. And again, to really kind of bring this home and see, well, what might this mean? I think it's very instructive to look at the Beacon community. So is Western New York in the house? Okay, well, you got to check out what they're doing. So the Western New York Beacon community is testing how telemonitoring can help keep high-risk diabetics healthy at home. So what's happening is patients are being installed in the patient's homes electronically and sending vitals, including blood pressure, glucose levels, and weight, to home health care providers through the Regional Health Information Exchange securely, protecting privacy. And then patients are getting feedback about how their behaviors impact their health, and suggestions as to how to improve health. So 3 months after joining this telemonitoring pilot, 71-year-old diabetic female reduced her glucose and hemoglobin A1C levels to the point where she was taken off the medication she was taking and getting to better outcomes, taken off the medication by her primary care doc. So I think it's Leonard Kish who said that patient engagement could be the blockbuster drug of the 21st century. I think that all of us, who care enormously about diabetes care know the truth of that statement, for diabetes in particular. If you actually liberate patients' data so they can get it, and if you actually have tools and infrastructure built to actually help patients take advantage of that, then I think you'll hear that story about that diabetic patient replicated many more times. Let's put the patient at the center, truly at the center, not just in name, but in fact. And I think you'll see a revolution happening in diabetes care unlike anything we have seen before. So, there'll be a lot of talk today about the diabetes epidemic, the crisis, how a lot of trend lines are moving in the wrong direction. But let me tell you, I've actually never been more optimistic about the fight to conquer it. And I've never been more optimistic about the power and utility of data and IT in the hands of folks like you to actually win that fight. With the power of open data, with the power of change payment and HIT, and with the power of patient data liberation at our fingertips and riding along with us, I think there's just an enormous amount that we can do now that would have been inconceivable even just a few years ago. So we're very, very excited about this, and I actually am personally very passionate about this. If there's anything I can do to provide further information or be helpful to you in any way about any of this, then please contact me personally. I'll give you my email address. It's tpark, T-P-A-R-K, at, I apologize for this complicated email address, ostp.eop.gov. That's tpark at ostp.eop.gov. I read all my own email, and if you've heard me speak before, I have a protocol, actually, which is that if I don't get back to you within 3 days, please reply again, put "you idiot," and then your actual subject. Because what I do is I then search my Outlook by "you idiot," you see, right, and then I respond. And there's a hack that Tom Getz, the editor of Wired magazine, recently let everyone know, which is that if you put "you idiot" in the first email, right, you'll save yourself about 72 hours. So I encourage you to do that. And I don't just say this for fun, right? I mean, diabetes isn't going to be conquered by everyone working in their silo doing their darndest to end it, okay? Diabetes is too big a challenge for any one of us, any one sector, to take out by itself. So to really end diabetes, to really bring diabetes to our fight against diabetes to the point where we actually want it to be, we have to work together, which sounds like a really obvious statement, right? But I don't know that that's always happened in as vigorous and productive a way as it should. So when I give out my email, if I don't respond to you in 3 days, I really will have been an idiot. And I really should have responded to you. I really do want to work with you. We want to work with you as the U.S. government. So don't hesitate to reach out to me. And I can't wait to see what we can all do together. Thanks so much again for caring so much about this, to come hang out in D.C. Bright and early on Sunday morning. Thank you so much for everything that you've already done in this fight. Thank you so much for everything, even more so, I think, for what you're about to do. God bless you as you do it. May the force be with us all as we do it together. And God bless the United States of America. Thanks so much.
So I think we have time just to keep us on track for 1 or 2 questions. So if you have a question, raise your hand. We'll get a microphone to you. Please identify yourself. And we'll see if we can have Todd just give a few more great words of wisdom. Any takers?
Hi, I'm Kim Angelides from EOS Health. Great talk. There's a lot of data out there. It's fantastic. The question is that who's going to look at the sort of the integrity or the usefulness of it? You know, you can get an aggregation of data, which is, who decides whether it's going to be meaningful, because you're going to have just tomes of data. Are there any efforts that are going on now in trying to decipher or determine what are, good sets of data and what are bad sets of data? We all get bad sets of data.
Yeah, it's a great question, and I think that as you know, there are a lot of efforts actually to do this, and there are a lot of efforts to actually assess the data and try to figure out what's more useful or not. I think that one fundamental tenet of the open data movement is that data will actually get better if you have a more open conversation about it, right? So if you only have certain people have the data and only they are the oracles who are allowed to get insight from the data, I think you'll actually not see as much data-driven improvement and data quality improvement as if you actually make the data available to everyone, and everyone can interrogate it in a truly democratized way to figure out, well, how can this data really be applied and interpreted in a way that best improves the management of diabetes. And so I think we're real believers in democratization leading to better data quality. But that depends, of course, upon people being interested in it and scrubbing into it. But I think this topic in particular is one where there's a lot of people who are really interested in it, and there's a lot of folks who are weighing in, and I think that's all to the good.
All right, one more.
As of today, what's the single data program that the patient uses to treat diabetes in your experience? As of today, is there any therapeutic data or software program where patient uses it at home to treat diabetes?
So if I understood the question correctly, I mean, there are quite a lot, actually. I'm sorry? Got it. So, I mean, there is quite a lot happening, and I'm certainly not personally aware of all of what's actually happening, although I try to keep up. But there is a lot going on. I would look to the Beacon communities. I actually look to really a lot of young startups to actually see what they're doing. I think one of the things that I think is most striking about what I'm seeing just in general is that a lot of the most spectacular work that's being done is actually generally not known in the mainstream. And that one of the best things that could happen is to actually try to really reach out and try to find, right, what is happening in places around the country very quietly that's extraordinary that nobody knows about, that can help not just with management but with actual treatment. So another one of my favorite sayings, is by William Gibson, who's a cyberpunk author, and he once said, the future's already here, it's just not evenly distributed yet. And I think that's particularly true of healthcare right now and of diabetes care and diabetes management, diabetes treatment. There is an enormous amount of innovation happening, maybe more innovation, certainly using data and IT, than has happened maybe in the history of this issue. But a lot of it is really not known. And so I think a systematic effort to go find that stuff assess it, see what's working, what's not working, and kind of accelerate collective learning would be an extraordinarily good thing to do. One more?
Last one.
Yes, David Craze with Physicians Proviso. I should say also that we were one of the winners of one of the Codathons in DC. Thank you. I've had a question. You know, you're opening up all this data, the data sets from government and from payers, but one of the big problems is most of the device manufacturers don't have open APIs. And getting device data is one of the biggest problems, especially at the practice level. What's being done in that initiative?
Oh, yeah. So we are very excited about that.
Mike?
Kind of make a long story short, this is an issue about which this is an issue in which we're very, very interested. And I'd love to talk to you more about that. We've been talking to folks like Hugo Campo, who's a patient who's been trying to get data kind of out of his defibrillator for, I think, years now. And it's his defibrillator. It's his heart, right? It should be his data. And he can't seem to get access to it, which strikes us as a little weird, right? So we're eager to learn more about this and actually engage in conversations with everyone we need to about this and see what we can do. Because to us, it's just basically, it fits in the same category of Blue Button in general, right? I mean, it's your data. You should be able to get access to your own data. And if you think about the growing ubiquity and use of devices, right? If you get access to all your own data except for the data in devices, that's kind of a large omission, right? And then there are issues around how you do that and how you do that in a way that's not, unscalable and so on and so forth, right? But we're just super early in this conversation with a bunch of folks, but we're very interested in learning more. And so if you have insight into this or have leads as to who we can talk to, just learn more about it and get a good baseline and figure out kind of what the right next steps might be, that'd be fantastic. And again, you can contact me at tpark@ostp.eop.gov. Okay? All right. Thanks so much. Have a great conference.